introduce yourself, please. Tell me where you're from and your individual philosophies for how you approach hospital at home, because you do have two different philosophies in this realm.
So I'm Jackleen Samuel. I'm the founder of Resilient Healthcare. We're based out of Plano, Texas, but I'm from New Jersey, which I like to remind everyone, even though I've been there 11 years. We are a hospital at home company. We contract with hospitals. We took a little bit of a different approach. Since we started, we've actually shifted a few times over the last 6 years, but we're a healthcare technology company is how we label ourselves, and we enable hospitals to provide this care. And so we sell into hospitals, and then we establish an infrastructure for them so that they can provide high acuity care in their communities. And then we work with home health agencies to deliver a lot of that care.
All right, Kevin Riddleberger. I'm the co-founder of Dispatch Health. Dispatch Health is headquartered in Denver, Colorado, where we got our start, now servicing all across the country, 30 states, 50 markets. And we really set ourselves up about 10 years ago, really focused on high acuity intervention inside the home, and started in the pre-hospital space, being able to be an adjunct to community providers, to be a new tool that they could deploy inside the home to be able to avoid unnecessary trips to the emergency department. So as you know, many folks that are in the emergency department really don't need to be in the emergency department, and we saw an opportunity to be able to really align with the triple aim to be able to provide a great experience, drive down costs, as well as improve clinical outcomes. And since then, that has evolved to be able to add different clinical services onto the platform to also include hospital-level care in the home. And we deployed this pre-COVID, with contracting directly with MA plans. And then coming out of COVID, as folks may know, CMS granted a waiver program where hospitals could get paid for hospital-level care being performed in the home versus being performed in the hospital setting. So that's where we transitioned as well, to be able to help health systems deploy that model and decant their hospitals.
Sounds good. Thank you to you both. Jackleen, you and I were talking an hour or two ago about what were some of the things that the post-acute providers in this room need to know about if they know that if they don't want to miss the boat, in other words.
So we started about a year before the pandemic, and our goal was to recreate the hospital setting in patients' homes, but not necessarily the acute care model. So we really started in that palliative chronic care management for patients in their homes. And when we started, we were the employer of providers. And so we employed the PTs, the nurses, the physicians, the nurse practitioners, you name it. And throughout the pandemic, Medicare approved the hospital at home program, and so we quickly shifted to working with hospitals to provide acute care at home with the hospitals. We were the first group to contract in Texas and launch the hospital at home program with Medicare, and that was a HCIF pilot program with Medical City. And we realized then that we're more of an enabler for hospitals to provide this care, and why would we recreate something that already exists? My background is in physical therapy and home health specifically. Most of our leadership has got a clinical background in home health, and so home health agencies exist and they do a very good job of delivering care in the home. So why don't we work with them and with the hospitals to really bridge that gap in care and treat acute care patients at home, as well as follow those patients throughout their life cycle? And so we partner with home health agencies. We provide acute care home models for hospitals through technology. We're very platform driven. And we bring all the vendors together on that platform, and it manages the credentialing, the training of the nurses, the dispatching of the nurses, the virtual care, et cetera. And then we work with home health agencies so we can actually utilize their staff in there. Our model has really shifted into acute care at home. Patients discharge as they normally would, and a lot of times to home health agencies. And so there's a continuum of care between the clinicians that are treating them in the hospital at home program with us in the hospital, as well as moving on to traditional home health And then we've launched primary care at home and outpatient services at home with a number of hospitals, mostly because we're unsure of where the waiver is going to go. Hopefully it does get extended, but we also started in that space before acute care at home was a thing. And so we see another continuum of care there where they see that home health agency for traditional care in between, and then they get an added on service with the primary care at home through our programs with the hospitals.
Cool. Kevin, let's stick with the same question. What's the the best way for home health providers to kind of catch this hospital at home wave?
Yeah, I guess I would take a step back and maybe define what hospital home is, because I think the terminology gets thrown out there right now, and there's a lot of different flavors, I guess. And you could look at models that help patients transition a little bit earlier safely coming out of the hospital and to be able to get back into the home setting and wrapping additional services around them. And then you have to look at, all right, who's the billing entity around that? Are they still meeting hospital level of care as they transition out of the hospital and into the home? If they are, that billing entity can still be that hospital. But true hospital home model, which is now defined by CMS, patients need to identify themselves inside of an emergency department. They are worked up inside of those emergency departments, and they need to meet admission criteria inside of the walls of a hospital. So, using Milliman MCG, criteria, they need to qualify for a DRG level of care, inside the home. If they do that, that entity is able to provide that level of service and consent, from the patient by transitioning them into the home, setting. So, and then with that, there's many standards that need to be met relative to the care that's being provided and the services that are being provided inside the home during that episode of care. So, if you take your typical hospitalization, there's many things that happen, during that 2 to 5 days that patient is on a hospital floor. How do you reproduce that inside of a home setting safely? And CMS is giving some guardrails as to what they need to be doing. And, part of that is nursing care. And so, every single patient that gets admitted, into the home setting needs to have at least 2 daily visits by skilled nursing capabilities. So just like, rounding on patients, in the hospital with nurses, you got to do that, in the hospital or in the home twice a day. You also have to have advanced practice provider or physician rounding at least once a day. And so where home health agencies can get involved is really being, a entity that is working with the hospital, working with services like ours, that could be an extension of that care team. And this is all about a care team. It's not one individual entity going out. It's a team that is coordinating those services together to be able to get optimal outcomes for that patient, inside the home setting. So there's a lot of, we could spend this whole day, just talking about hospital at home. And so we'll probably touch on the 10,000 foot level, today, and happy to, talk later on the specifics. But it's an amazing model that has amazing clinical outcomes that I'm sure we'll get into. That is generating a lot of value, to patients and patients' family members.
That's a good segue would be, let's stick with that. What are the outcomes we're seeing? What are the data that has been produced thus far that kind of shows unequivocally that this is a good model, it's an efficacious model, it's something that can be reproduced again and again, and to add to that efficacy? I'll stick with you, Kevin, and then Jackleen, let's go to you after.
Yeah, I think, we're seeing now more and more studies. This has been a model that has been studied in the US for 20, 30 years. Started out of Johns Hopkins with a guy named Dr. Bruce Leff, who's a geriatrician. And we're seeing more clinical validation studies come out. And each study is really showing similar results. Patients love it. Families love it. Outcomes are better than your typical hospitalization. So if you look at 30-day readmission rates, most programs consistently are demonstrating between a 7 to 9% 30-day all-cause readmission rate. So if you compare that to the typical CMS data of around 18 to 22% 30-day readmission rates, fantastic results being able to do that. And so those are the big data points around this. I think you're seeing less falls. You're seeing better cognitive response on patients being in their home setting. It's less of a strain on caregivers because you have the support staff around them. But it's still in the early innings. If you look at the percentage of number of patients admitted inside the home versus all of Medicare admissions, it's a fraction, right now. You're starting to see a rise, in this, and this is why CMS is continuing to look at this as a way to extend it, because we need more and more data to be able to have permanent legislation put in place to allow for continued expansion.
So these patients are lower acuity admission. They're sick enough to be in the hospital and they qualify to be in the hospital, but they're stable enough to be home. And so a lot of the research coming out and the data proving that it's a lower cost of care, it's a reduced readmission rate, it's a reduced length of stay, it tracks because these patients are not as sick as the entire Medicare population of patients. We started honing in a little bit more on access to care. We have a JV with Community Hospital Corp, and so we have a lot of rural critical access type hospitals. And so access to care, patient compliance, especially in those areas where historically they would have to go somewhere for an IV for 10 days, or they'd be admitted for 10 days for an IV and then go home and have to have follow-up care that they just don't get to because they're 45 minutes away from the closest clinician. So access to care, we've seen an improvement. Compliance for patients, significant improvement. I think that it's like 97% now patients would prefer to be treated at home. So it's a patient-driven model. And then cost of care is interesting. When we first started, it was just Medicare. And Medicare said Medicare Advantage plans can absolutely do this, but you have to go to each plan. And it was a lot of educating payers that this is a better cost of care and better patient outcomes. And it's everything that it needs to be. And when it first started, we did not get a lot of feedback. Now, our latest hospital that just got approval couple months ago, we notified the payers, and the payers are like, here's our policy and procedures for hospital at home programs, here is what we pay for them, and there's a payment mechanism for it too. And so I think cost of care data will drive a lot of that kind of outcome as well.
Got you. I remember, Jackleen, you and I interviewed you several months ago for an article for a report that we have that's free. It's called The Future of Home Care, and you can download it on our website. But I remember I kind of gave you a hypothetical scenario. I was like, okay, so there's this dude, he's in his early 60s, he just had a mild heart attack, went to the ER, they found out what it was, he's stable, but instead of being admitted to the hospital, he's admitted to his couch, is what you said, which sounds like a good place to be admitted to. So you said he left with a care plan. Somebody visited him that day. His medications were available, and that's where he was going to be. Now, it sounded pretty complicated. It sounded pretty holistic. How far away are we from having that scenario be the norm rather than some of the exceptions that we've been talking about today, even though it's in the works?
I don't remember what I said in that interview. So
you weren't drinking, I can tell you that.
We often say that we are a logistics company. We're recreating healthcare, hospital care in patients' homes, and that is a lot of logistics. What time is the medication going to come? Is there a phlebotomist that's going to do the lab draw? How long does it take to get the results from the lab? Is it going back to the hospital's lab? And even with the Medicare waiver for the hospital to be approved, it's all logistics. It's workflows. It's how are you going to deliver all of these things to the patient's homes and do it in a way that's efficient and safe for patients? And we built a platform that manages that logistics of care. When will this be the standard? There's a lot of, that's a loaded question because like right now we're waiting for Medicare to extend it for another 3 years. And so hopefully they do. I think that they will. We're pretty bullish on it, obviously, but we'll see. And then will it be? And we have a deep belief, and most of our hospitals that we work with too, is that this is the consumer-driven model. Patients want to be seen at home. Hospitals want to be able to provide this kind of care because they don't want the hospital next door to provide it and patients to choose that hospital because they could be treated at home. And so I really think it's just going to take a little bit of time for patients to know that this is available to them and that it doesn't change. You know, usually the first question is, do I have to pay extra for it? And that it falls under their benefits, that they can be treated at home. It's going to take a little bit of time for this to become the standard, but I think it will be driven by consumers asking for it.
I think the good news around your scenario is that that is happening every single day across the country. Now, it's happening in pockets, and it's happening, you know, only on certain percentage of patients that are in those clinical scenarios that justify safely transitioning those patients in the home. But, you know, I think where we can get patients that meet this qualification up to about 20 to 30% of typical med-surg DRGs, then we will be, you know, in a much better, you know, place. We're probably, you know, in that single digit, you know, range, you know, right now, and we have a lot of, you know, upside moving forward. But the beauty, this is patient-centric. It's the right thing to do in our industry. And it's right-sizing the care. Not all patients need to be in a institution, you know, based hospital, you know, for that level of care. And, you know, we've seen some of the graphs today around the aging, you know, population. We can't build enough hospitals and enough beds to be able to support this rising sick, you know, population. So we need to decant that safely. And what better place than in the home setting to be able to do it and truly right-size the care that's coming into those hospital settings.
To follow on that, Dr. Leff's research in the 90s showed that 30% of patients could be safely treated at home. And this was before technology. We've had so many technical advances since then, you know, dialysis at home and monitoring 24/7, real-time, continuous algorithms, AI, all of that. And in the 90s, it was 30% of patients could be treated at home. Who knows what it'll be now or what it'll be 10 years from now when AI is full-blown being used in healthcare.
That's a very good segue to the next question, which is currently AI, various tech tools, are they sufficient enough currently to meet the growing demand that we're going to see in this in hospital at home? And if they aren't, what are the advancements that the two of you, I guess, would like to see be made in order to meet the needs of this growing population?
AI is only as smart as much data that it gets, and this is still a pretty new setting of care. And so I think as traction grows, then the AI will become more advanced. And it's also, it's loaded because there's administrative, there's logistics of care, there's clinical care, predictive analytics, and there's so many different verticals that AI can be used in. And so are we there yet? Definitely not. Will we get there? I think it'll take us some time for each sector of that. Especially administrative work. I mean, what is it, 25% of the $4 trillion we use a year on healthcare is spent on administrative work. not doctors, not actual medical care administration.
Right.
And so I'm hoping to see AI influence that, especially in driving care home.
Yeah, I mean, I think technology will continue to play, a role, and it always should play a role in the advancements, of in whatever we're doing. Um, I think there's so many aspects, to this. You talked about the logistics, piece. That is a huge, huge component, to be able to run this more efficiently and to be able to scale. And that's important. You can run, a program and admit 1 to 5, patients, per week from a manual basis and kind of orchestrate things on who needs to be where. But to have more sophisticated logistics platforms, which really no one has off the shelf. That's why you have companies like ours and many others that are building kind of platforms to help understand who needs to be where based on the patient, needs, and what coordinated services need to be, inside the home. It's a big puzzle. I think large language models are going to be, helpful from a predictive, standpoint to be able to guide some of the logistics. Some of the remote patient monitoring right now is fine. It does the job, but if we can be smarter with the data that we're consuming, and it's no different than the data that hospitals are consuming to be able to start to identify, patients that are having issues, we're going to need to replicate that exact same experience inside the home setting.
Cool. Couple of themes I think have emerged so far today. And one of the most powerful ones, I think, is the theme of collaboration, cooperation between the different arms of the at-home care octopus, if you will. I'm wondering, how does hospital at home kind of fit into this theme of collaboration, this collaborative, cooperative motivation that we have heard from several different speakers today in order to advance holistically efficiency, patient outcomes, et cetera, et cetera. And both of you can take a stab at that.
I actually don't think there's any other model that helps with collaboration more than a true hospital home admission. It is imperative that everyone's working together. They're operating, essentially off of one system. That it's one reimbursement, mechanism, and then some subcontracting, from that. So it's closer to true value-based care than we really ever have been. And so the more that we are all in it for the right reasons together, and it's all about reducing costs and improving clinical outcomes, that's all about it. And so I'm very optimistic that if we can continue doing that in other models that are around the home setting, then we're going to have a lot of success, moving forward.
Even think of an actual, like a hospital. You have pharmacies in there, you have so many collaborative DME, medication, labs, and now you're recreating that in the home, and you have an opportunity to do it in a way that we're not learning. We're learning from past mistakes, and we're breaking old habits, and we're delivering it in the home. But now you have all of these departments, which are typically around, like IV infusion at home. Companies have been around forever. Physician services that are visiting homes have been around forever. And so you're piecing a fragmented at-home model together so that you can collaborate to treat an acute care patient at home. And I think that's really been the issue with home-based care in America historically. I mean, we started the company, my dad had a stroke and was spending a lot of time back and forth from home to hospital. And a lot of the things he was being admitted for, he could have received at home had the hospital system been aware that IV infusion at home existed in that area, or a physician was actually diagnosing and treating in the home rather than just sending back to the ER. And so this is, I agree with Kevin, it's the first model that everybody gets to collaborate to treat one patient in the home. And if you do it in a way that's efficient, I mean, Medicare pays a DRG to these hospitals, and so it is very value-based. They get penalized if they have a high readmission rate. That all carries into hospital at home services as well.
The only thing I would add on to that too is that the home, as everyone knows in this room, is now a super complicated place, to be and to understand. And so we had the senator on, today. There's many folks, her colleagues, in the House and Senate, that really have no idea what is happening, inside the home setting. They may have a historical view on really what is home care. There is, it's really a system of care that's being provided inside the home, now. And so how do you differentiate all of the type of clinical models and payment models? Who needs to be where? Who's allowed to do what, inside the home, from physician services to nurse practitioner PA services to nurses to paramedics to techs and aides. I mean, it's a full system. And so how do we now, understand and the ability to work together and help educate, the community on the complexity, but also the opportunity, moving forward that we have by keeping patients safely inside their homes and delivering amazing clinical care.
Sounds good. We're a little bit over on time. Thank you both for a very fruitful discussion. Let's hear it for Kevin and Jackleen, please.